the topic that I was going to talk about today, obviously, let's see. Okay. As Dr. Boyle mentioned, so this is a drug with MEK inhibitors that we use, but is not currently FDA approved as the BRAF inhibitors are primary approval based on the mutation. But the reason I wanted to talk about MEK inhibitors is as Dr. Boyle, we do have a large proportion of mutations and cases that are non-BRAF mutated. And in addition to that, as was noted, we do have activity against either BRAF mutated histiocytoses and Erdheim-Chester cases that can respond to MEK inhibition. And so as an oncologist who uses both of these drugs in other cancers as well, we have gained some experience with managing some of the side effects of these drugs. And as potentially into the future, we have more opportunities or even have more opportunities to patients to maybe decide with the physician which drug or drug combinations may be for you. I thought it could be helpful that we discuss some of the side effects we've learned about MEK inhibition, primarily from other cancers, mainly because we have more data. So I have no financial disclosure or conflict of interest. And there will be a little bit of repetition in this talk from what Dr. Boyle has mentioned, but I do think it can help just zoom out in terms of how we treat cancer and disease in general and how that's changed over really the last century. And Dr. Boyle noted, we've really moved into a modern era of targeted molecular medicine, and that's what these drugs that we're talking about have to do with. So, as someone who's interested in history, if we think about how cancer or any disease used to be treated, all we could really do was look at things anatomically. We could say there was something growing on someone's skin or someone's lungs were diseased because they couldn't breathe. And that was about the extent of it. We had no microscopes. We had no ability to do anything more sophisticated than that. Our treatments may have been equally, shall we say, medieval, potentially effective at times. But, and we invented a microscope, and we all of a sudden could look inside these organs and see cells, and we realized that there's things happening that we may not have known about before. And we may realize that that lump in the skin is the same thing as lump in the lung, or that thing that's happening in the brain may actually be the same thing that's happening somewhere else in the body. And we start to create these new diseases that we didn't know about. And this was really the story of the last 200 years. As we started to do that and new technology came out, we began to use better and better biochemical methods and better technology to study what was happening in those cells. And we found all of these complex circuits. If any of you guys work with electricity, that's really probably the best metaphor. Very complex chemical circuits that make these cells do what they do. The complexity is quite astounding. This has nothing to do with Erdheim-Chester disease, but it is, I thought, just a nice, it looks like a very, very complex subway system. But it's a model or a metaphor for saying inside these cells, inside these diseases, some very complex but oftentimes knowable changes have occurred. And finally, in the last 30 years, as we've been able to sequence genomes and analyze genes and DNA, we've started to be able to get to really the root of all of these things, these proteins that are abnormal, and find the mutations that have made them that way, and actually elucidate very, very specific baseline problems, as Dr. Goyle mentioned. And that brings us to the exact pathway that we talked about that we have now learned plays such a key role in the histiocytic disorders. While there are others, this central kind of skeleton or backbone really drives a lot in terms of a few mutated proteins that may end up resulting in all of the abnormalities of the organ systems that we've discussed. And so, as you can see, and as we've talked about before, the BRAF proteins and the signaling pathways with MEK downstream from that, a majority of the mutations that occur in Erdheim-Chester will occur at the BRAF site. And we have drugs that target that, as many of you and most of you are probably aware. And the MEK inhibitors are the drugs that target MEK, as well as they will work in BRAF mutated Erdheim-Chester. but that will be the those will be the drugs that I'll be discussing now in terms of their side effects. So in regards to the potential for combined BRAF/MEK inhibition, as I think you were noting in the clinical trial that you're on in Missouri. So this is actually something we do in melanoma pretty frequently, and actually it's the primary way we treat BRAF mutated melanoma is by giving both drugs. It has its own set of side effects when we treat melanoma with these two drugs combined. Notably, and particularly, it can produce a lot of what's called pyrexia or constitutional symptoms, where patients will kind of feel like they have the flu, quite frankly, even though they have no infection going on. It can be relatively debilitating, but we can sometimes manage it. But it may be one reason why the single agent drugs and not using both may be of benefit from a side effect standpoint. Also, given that there seems to be such a central, like Dr. Goyle mentioned, oncogenic addiction, or such a central role in these specific mutations outside of other mutations, perhaps we get more activity from a more targeted approach. But there are, I believe, active clinical trials right now looking at the combination therapy as well. And then as we just talk about toxicity in general for drugs, there would be two things I would note. So one, whenever we're talking about the side effects that can occur from a drug, particularly with cancer or conditions that are affecting multiple organs, we have to balance the potential side effects of the drug with whatever side effects that disease is causing prior to starting the drug. And while the list of side effects may be long at times, oftentimes the way that patients feel better from their disease getting under control will outweigh some of the side effects that may occur from the drug. And that's not always the case, but that is, as you have these discussions with your physicians in the future, it is always something that you have to balance. And the other point that I would just make, and this is maybe within the context of some of the conversations we've been having in general today, as you meet with specialist doctors like oncologists, like pulmonologists, I think what you will find that differs perhaps from a primary care doctor or someone who's managing a lot more patients with a lot more disease types is the drugs that those doctors will use in these specialist clinics. They tend to be more monitored drugs, and therefore the culture of that clinic is going to involve more frequent monitoring. You'll probably be asked a lot more questions about, are you having any side effects? And also you will be probably in a system where treating those side effects is a much more aggressive process, where we'll be trying to figure out, okay, what are they and how can we mitigate those? So just as a culture shift from any kind of experience, that if you're kind of new to this, and it doesn't sound like most people are new to this disease right now, but if you're kind of new to a rare disease or any kind of cancer, oftentimes people may be a little surprised about how much more frequently they visit their doctor, how much more intensive the discussion is regarding, are you having side effects and how can we manage them? So again, I think most of you probably know this, but how do we know what the side effects of a drug are and what rate they occur? This is largely going to occur from the clinical trials that we do, where we enroll lots of patients, and then we keep very fastidious records in determining how are you feeling, what side effects are you having, and then documenting those side effects so that we all know moving forward, this seems to happen about at this rate. This side effect seems to happen about at this rate. In addition to that, once a drug is approved by the FDA, we will continue to have what's called post-marketing surveillance. And if new toxicities emerge, like if you were to contact Dr. Goyle about a late side effect that may have occurred, that may be something that's added later that we don't know about yet. But one of the problems obviously with rare diseases is because it's rare, we can't necessarily always capture as much knowledge about what toxicities may exist. And so the nice thing about at least the BRAF inhibitors and the MEK inhibitors is that we do have a relatively large exposure and experience with these drugs through different cancer types. And that's what I'm going to be borrowing a lot of this information from today, is some of the toxicities that we've learned about these drugs by studying them in conditions like melanoma. So this is a picture of a melanoma. on the left, a couple various melanomas, and then on the right, you can see the patient with melanoma that's metastasized throughout their skin. And in the second picture, picture B, you can see what happened after they got the dual BRAF MEK inhibition. But the point would be is a very dramatic response in a different disease type. And this is where we've learned a lot about what happens with these drugs. So this is just a picture of what what a typical paper would look like that studies these things in what's called a clinical trial. And this was a paper that studied a MEK inhibitor, specifically cobimetinib, in melanoma. It's called a phase 3 trial. And you can see at the top, there were 269 patients who got the drug. So from that number of 269 patients, we're able to get a decent amount of information about what the side effects may be. And this is typically how it'll be presented. It'll list the side effects that occur in patients most commonly, and then we'll list the percentage of those side effects. And I know it's a little small to read. And you can see it sounds like a commercial you may see for a drug where they rapidly list off lots of side effects at the end of it. But the important thing, I think, is to know there's going to be some common side effects, and those are the ones we really want to focus on knowing about. This is another paper that looked at trametinib, which is another MEK inhibitor. They looked at this in ovarian cancer, and you see a similar table that goes over side effects. So by comparing, this study had 228 patients who got the drug. So between these two studies, we're now over 450 to 500 patients who have received a MEK inhibitor, which gives us more and more confidence to say these are probably the side effects that would occur. And so now I'm going to go over some of those side effects specifically and how we might manage some of those side effects. So acneiform rash, acneiform is kind of what it sounds like, acne. This is a rash that can commonly occur with giving a MEK inhibitor, as well as other drugs that target that central axis that we talked about. Other rashes can occur. Skin findings, as we mentioned, are not an uncommon side effect of these drugs. And so this is actually a picture just so you can kind of know what it looks like. So this is someone's back who's got a relatively diffuse process. This is involving a decently large amount of body surface. I'm sure all of you came here so that you could see pictures of rashes. But this is what the rash may look like. It can also occur on the face and other parts of the body. And in terms of management, we have a very, very worked out and specific way that we do manage this. So we assess the degree of the involvement of the rash, how much of the body it involves. And then basically we can escalate the amount of intervention we provide based on the severity and the response to the treatment. And so we don't have to go over all of this specifically, but the point I would want you guys to take away from this is for any side effect of any drug, typically we will have a relatively worked out algorithm for how we would address those side effects, how we may be able to make them less so. And if we can't make them less or if they become dangerous, the option would always be just stopping the drug and trying something different. But between steroid creams, antibiotics, and other interventions, we can oftentimes reduce the severity of the rash that may occur secondary to these MEK inhibitors. Gastrointestinal side effects are another common side effect that may occur with MEK inhibition. Diarrhea is not uncommon. Fortunately, with diarrhea, we do have relatively good drugs that we can give a large amount of, usually titrating it up to the amount of diarrhea that may occur. Things like Imodium that often do work quite well if we find the right dose to give you. So sometimes that may just be a back and forth conversation with your physician, finding how to treat that in a way that makes it to where it's not any major issue for you. And nausea and vomiting, mostly mild nausea. It ranged from anywhere from 25 to 60% in the studies. Again, mostly we can manage this pretty well. Either it's not bad enough that you need to do anything and it's just maybe a mild reduction in appetite. If it becomes more severe, usually we can give you any host of drugs that will help mitigate the feeling of nausea. So we do. Have I seen any intestinal ruptures? Not personally. And I think it would be It would be an atypical side effect for the complications, but go ahead.
She had one report.
Okay.
Saturday, Friday morning, Saturday. Normal is 5 days. Twice, 20, 40 later. I always, it's one of those things that nobody can pinpoint any stuff. It's such a narrow window that we can look at. It's just sometimes you just wonder if they're tracking some of the development through the camera is what my thought. Because you've been on that since 11.
Sure.
So I don't know.
I think it's a great question, and I don't know if Dr. Goyle, if you've had any sort of case series that has elucidated that. I do think while the microphone's being brought over, I do think an important learning point that you're bringing up would be because we often don't know when something happens if it's related. That's kind of what I was mentioning with the post-marketing analysis. It probably didn't happen with any of these 500 patients, otherwise that would have been reported. But that doesn't mean it's not related. After a drug has been approved and sort of the data is out there, it is important that side effects that may have occurred long after the fact are, written down where the drug company is notified of it, so that if there is a small accumulation of these events, and after the fact we say, could this be a connection, that would then enter back into the labeling of the drug so that the community would know about it.
I have not seen that happen myself, but I know
You were there.
before. Yeah, the side report. The side effects of treatments are in two categories. Talk about one is the expected side effects, and the other the idiosyncratic side effects, which we don't know what happens. Can happen already. Tough to say the term cause that or the generic cause that, but I'll give you an example. So we saw pancreatitis as a side effect. Well, we saw a case with pancreatitis, and who was on cobimetinib, the Delborab. And then we saw another one, and then we asked our friends, had a ECBGA meeting as a result. We put together 300 patient data from 4 or 5 results. So, but it is rare, but it is real then. So, so hard to say, but anything that develops could be potentially. I don't think that's something that is traditionally considered to be a side effect.
The only reason I asked is because we have a lab in our basement. That's technically right, but we test for glyphosate and we have to make bacteria. So a lot of the equipment, it's the rare and oddly battles. My scientific mind, I think it was 1 to 5%. 1 to 5% in our annual. Big issue sometimes.
Yeah, and the other thing to remember is the rare side effect we use in this one of the concept and the side effect. It is very important.
Yeah, and I think this is I think this is a really valuable conversation in general. Anytime someone is on a novel or a rare agent that's not used as often as the other types of drugs we use in hypertension and diabetes, I do think it's important to maintain a high index of suspicion if something happens that we don't understand. So edema, something that is relatively common in other conditions, but that can get worse or occur in regards to use of MEK inhibitors. Can result in swelling of the legs. We can try to manage this with some low-dose water pills, with compression stockings, etc. If the edema were to become really debilitating and non-responsive to basic interventions, it may be something that we would consider decreasing the dose on, but most often this would be a side effect that if the disease was getting well controlled and it was only mild, it may be some something that you would want to manage with just conservative measures like compression stocking. Briefly just talking about some heart side effects that can occur with the drug. These are less common, but they can occur, and so we definitely want to be keeping an eye out for them. So on a very basic level, you can get mostly what's called grade 1, which is just about a 10-point rise in your systolic blood pressure from the use of MEK inhibition. This is going to be mainly concerning to us if you already have some baseline blood pressure issues, or if you're on a lot of blood pressure drugs already. We may want to be particularly cautious, or at least observant about seeing if your blood pressure is going up in a higher way, or if there's already symptoms from that. But most of the blood pressure rise that comes from this is going to be mild and not significant. And this is probably even less common, but certainly something that we would at least probably want to check on a baseline level, and that's something called QTc prolongation, which just refers to a slight electrical change in one part of the electrical system of the heart. The main thing we would want to be looking out for is if you already had some degree of QTc prolongation. We may want to screen you and monitor you with EKGs, which is about a 5-minute test, just to make sure it's not becoming too long. Go ahead.
So third, one of the things they found in 8 was pericardial.
Sure.
Was pericardial fluid.
Sure.
We've never gotten an answer yet. I mean, you ask the question. What is the long-term effect to the pericardial that she would have? Between the lung, the left lung is the first given that was. The male still didn't know what it was at that time.
Mm-hmm.
Still questioning a ton of that. I can't remember. I know it was over the 14 days. I think we pulled off. It was like 5 Coke bottles.
Sure.
Bottles, so fluid off her heart, lung.
And they thought it was from the cobimetinib.
They didn't know.
We don't know.
It was autoimmune, and the
Sure.
standard question or answer was, there's 2,000 on the immunity, but yes, everything to worry about with pericardial. I know it's off subject, and I apologize.
No, so no problem. So I mean, what we can look at is kind of the list in general with these large populations, and I don't think it's a common enough side effect that it gets caught in these clinical trials. Again, just like your last question, it's certainly possible that it was related, and just like your last question, it can be, because the pericardium is a very small area and any fluid in there can be a dangerous situation. It is a severe process, whether it was from the drug or not. So certainly a process that would be with.
Before she got diagnosed, before she went on anything.
Sure.
So that was.
Yeah.
Yeah, we measure every year at Summit Mayo and a lot of it at Barnes. But we have yet, EKGs come back good.
Sure.
Everything else is. We've seen no detrimental harm from it.
Sure.
But it's just, you just wonder if there's that much fluid on pericardial. Because they say when you look at them, my sister-in-law runs Mayo's radiology department.
Sure.
And she says when you look at them, the testing, it's like someone flipped the sheet, like along it, like when you flip the sheet to put it on the bed. That's kind of the infection. It's the same thing. Even though the pericardial is smaller, but she can't answer it because it's out of her scope.
Sure.
Where sometimes we brought all the doctors together and tried to figure out more of this, and it was more or less a swinging contest to figure out who had the biggest knowledge. And that's not really what I was looking for. I was wanting to find collaborative effort, kind of like with Rutgers. We did a lot of work with Rutgers to bring all these departments together to be able to find an answer to the problem,
sure,
which was good science.
Yeah, absolutely. I mean, trying to explore cause and effect is a difficult process, but one I think that you're right. We have to be diligent about whenever something happens that may be unexpected. So it sounds like it was a very major process and complication from.
In my life, I put a $19 million fertilizer company to her.
Sure.
So it was very, very life-changing.
I know everyone in this room has probably been through a lot of different things with the disease or with someone who they know who has it. So thank you for sharing that. One thing that is worth knowing for you guys is if you did have some baseline QTc prolongation and this was, you were going to go on one of these drugs, sometimes we might be a little bit more sensitive or ginger in regards to using medicines that treat nausea, because they too can they can prolong it, as can a lot of medications. So knowing your medications, making sure you talk to your doctor about any new medication starts can be helpful to make sure that we're not having any kind of drug-to-drug interference. And then there's a couple rare side effects, but that we call class effects to MEK inhibition, which means that they're probably true across all MEK inhibitors. It doesn't necessarily mean they're common, but again, it's something that's worth knowing because they're unique. So one of those is in particular regards to what's called retinopathies. And the retina is essentially the kind of the back part of the eye. It's a little bit small, but through that yellow line on the back, into the optic nerve, which then goes into the brain. So probably the most common thing, and again, it's not common, it's less than 5% of the time, but there can be a little bit of swelling of the retina that you would usually pick up with a patient may come in with a little bit of blurry vision. If the blurry vision wasn't treated, or if we didn't recognize it and continued with it, the side effect that could occur would be what's called a retinal detachment. Of the few cases that did occur with this, most of them were reversed as soon as they either decreased the dose of the drug or stopped the drug. But it's something worth knowing. If you start a drug like this, keeping an eye on any blurry vision is certainly something you'd want to be thinking about. And if you had it, talk to your doctor. There would also, you probably want to have a good relationship with an ophthalmologist or an optometrist who could look inside your eye to look at these things while you're being treated with it.
And not really good eye study right now. If you go to Mayo into Barnes,
Sure.
And it's pretty standard. You bring up the questions, and it's like you're in headlight. If you can tell, I'm somewhat persistent on my care for her. That's because we've gotten a lot of things done. But is there any place you can go for eye? Then I'm willing to travel because it makes sense. But I don't know if we really have a good eye specialist. We get the average individual, but it's it's like you're the expert.
So I think this is a fantastic question. It's one that I actually think about a lot because we have such a long list of new drugs that we've never had before, which they have extreme promise for so many different cancer types. They also have uncommon and rare toxicities that we haven't had to deal with in the past, and entire emerging fields of onco-ophthalmology are needing to develop, and probably have developed at Mayo Clinic, but may not have developed in smaller markets yet, because you have to have this extreme amount of specialization for a relatively rare set of side effects. Ideally, especially within the major cities that we have, we will continue to have more and more of these subspecialized specialists, ophthalmologists who take a particular interest in drug side effects from treatments for oncology. But you're right to recognize that there is probably a deficiency at this point. So we did have someone in Cincinnati who until very recently was very interested in this type of work. But I think we probably need to, it needs to develop. So finding those specialists, finding that expertise. I think to Dr. Goyle's point, that sounds like they're collaborating between Mayo and Birmingham. That's probably a model that we'll need to increase of having, because the specialists are so rare, having things spread out across even the country where you can get access to people who really know about these things. I don't know. I'm not sure what he's doing now. I know he was practicing until about 4 months ago, but I don't know where he is now. Yeah. So,
We're not that far.
Yeah. Sure. Yeah. But it's a fantastic question, and it's not just true for ophthalmology. It's true for really all of the organ systems that have specialists, finding people who take an interest in these disease types, these rare disease types, and the side effects of drugs is really of paramount importance as we get better, but also the knowledge expands. So you have to have more people to be able to grasp that knowledge and act on it. So good question. Any other questions? Okay, well, I hope this was helpful. And I think perhaps Dr. Kumar's talk may hopefully this will help lead into that as well. Thank you.